Good morning. Today's topic is on risk assessment. Risk assessment in periodontal disease, the learning outcomes are discuss the term risk indicator and risk factors, discuss the risk factors and predisposing factors that can influence the periodontal destruction, explain the effect of smoking on etiology and pathogenesis of periodontal disease, discuss the effects or contributory role of vitamin C deficiency on periodontia. Describe the periodontal manifestations in a diabetic patient. List the factors responsible for altered response seen in the tissues of a diabetic individual. Explain the pathogenesis of poor wound healing in a diabetic patient. And the last one, discuss interpretation of glycated hemoglobin levels. Coming to the introduction of risk assessment, the aim of risk assessment is to evaluate the prognosis reliability. Prognosis is an essential part of the periodontal care and it influences treatment planning considerably. From a clinical point of view, the stability of periodontal condition reflects a dynamic equilibrium between bacterial challenge and an effective host response. So coming to the risk. So it consists of various terminologies, that is risk factors, risk determinants, risk indicators and risk predictors. So before going to the details, what is risk? Risk is the probability that an individual will get a specific disease in a given period. So this comes before the diagnosis. That is the probability that an individual will get a specific disease in a given period of time. So coming to various risk assessments, that is, it can be defined by numerous components like risk factors, risk determinants, risk indicators. So first one, that is the risk factors. So it can be environmental, behavioral or biological factors which when present, which increases the likelihood that an individual will get the disease. That is risk factor. So what is risk determinant or background? So you know that background characteristics that cannot be changed or cannot be modified. So these are risk factors that cannot be modified. So that is risk determinant or risk background. Coming to risk indicators. Indicators, these are the factors which indicates the presence of disease. So these are probable or putative risk factors that have been identified in cross-sectional studies but not confirmed to longitudinal studies. Cross-sectional studies, these are studies that measures the outcome and exposures at the small period of time, whereas longitudinal studies for a long period of time. So that is risk indicators. And risk predictors or markers, also associated with increased risk for disease, which do not cause the disease. So these are associated with the disease, but it will not cause the disease. And these factors are also identified in both cross-sectional and longitudinal studies. For example, the lack of bleeding on probing does appear to serve as an excellent indicator of periodontal health, but the presence of bleeding on probing alone is not a good factor for the future attachment loss. That is risk predictor. So we will come into the details of each one and go into the details of each one. Risk elements for periodontal disease. The first one, there is the risk factors. Under that, we have several factors. There is tobacco smoking, diabetes, deficiency of vitamin C, pathogenic bacteria, microbial tooth deposits. So these are the factors. As we said before, this can be modified. Okay, and risk determinants or background characteristics, these are the risk factors that cannot be modified. For example, genetic factors, age, gender, socio-economic status, stress. So coming to risk indicators, these are risk factors that has been identified only through cross-sectional studies. That is, they are associated with this disease. For example, HIV or AIDS, osteoporosis, infrequent dental visits. So these are risk indicators. The risk markers or predictors. So these are the various factors that is which predicts the presence of disease can be. For example, previous history of periodontal disease will lead to again recurrence of disease if it is not if it is not treated properly or if it is not followed up properly. And also the bleeding on probing, as we said before, that is bleeding on probing. The presence of bleeding on probing is not a true indicator of disease, but the absence of bleeding on probing which determines the periodontal health. So, coming to the details of the first risk factor, that is tobacco smoking. It is a well defined risk factor for periodontitis. A direct relationship exists between smoking and the prevalence of the periodontal disease. So, as we know, the periodontal disease is caused by the imbalance between the bacterial challenge and the host response. So, these host response may be caused by changes in subgingival microflora, by the composition, or in the virulence factor. So in either way, it changes the host response to the bacterial challenge, and this leads to that is smoking is one of the factor which modifies the host response by increase in change in the subgingival microflora. So the association is independent of other factors such as oral hygiene or age. When comparing with the smokers and non-smokers, they've shown that smoking has a negative impact on the response to therapy. However, former smokers respond similarly to non-smokers. So coming to the effects of smoking on etiology and pathogenesis of periodontal disease. So we will be defining it in different aspects: microbiology, immunology, and physiology. As you all know, like smoke contains different components. It can be either gas, solid, which contains ammonia, nicotine, tar, benzene, etc. So this can affect on microbiological aspect, immunological aspect, and physiological aspect, which changes the human mycoflora basically and immune response also, which leading to the destruction of supporting structures of the teeth. So based on microbiology, there is no effect on the rate of plaque accumulation, where there is increased colonization of the shallow periodontal pockets by the periodontal pathogens. So there is increased colonization will be there, and also increase of periodontal pathogens in case of deep periodontal pockets. These are the changes on the microbiological aspects. Whereas in immunology, mainly the altered neutrophil chemotaxis, phagocytosis, and oxidative burst. There is a killing of foreign bodies by oxidative or non-oxidative mechanism. So these all will be altered. The defense mechanism is basically it will be altered in case of smoking, and there will be increased amount of tumor necrosis factor alpha and prostaglandin E2. There is the cytokines, mainly the inflammatory mediators, will be increased in GCF, and there will be increased neutrophil collagenase and elastase, the enzymes. The enzymes will be more in case of in smoking patients in GCF, and increased production of prostaglandin E2 by monocytes in response to lipopolysaccharides, the valence factor of bacteria. So in the response of this monocytes, there will be hyperresponsive act of monocytes, which leads to the increased production of inflammatory mediators. And coming to the physiological effects, decreased gingival blood vessels with increased inflammation, decreased GCF flow and bleeding on probing with increased inflammation, and decreased subgingival temperature and increased time needed to recover from LA. So there is a vasoconstriction. There will be vasoconstriction due to smoking, and when there is LA, then increased effect on vasoconstriction. So the increased time is needed to recover from LA. So coming to the next important risk factor, that is the diabetes. Diabetes, as you know, it is a complex metabolic disorder characterized by chronic hyperglycemia. You can see increased hyperglycemia in blood and in GCF. So this is mainly due to the diminished insulin production, impaired insulin action, or it can be a combination of both, which results in the inability of the glucose to be transported from bloodstream to the tissues. So which in turn lead to increased glucose level in blood and the excretion of sugar in the urine. So this is a clear risk factor for periodontitis in various aspects that we will be discussing later. So the prevalence and severity of periodontitis is significantly higher in patients with diabetes than in those without diabetes, and that the level of diabetic control is an important variable in this relationship. So this uncontrolled diabetes always end up in long-term complications such as microvascular diseases like retinopathy, nephropathy, or neuropathy, macrovascular disorders, increased susceptibility to infections, and poor wound healing. So coming to the oral manifestations. So oral manifestations include chelosis, mucosal drying, burning mouth or tongue, diminished salivary flow, Then alterations in the flora of the oral cavity, that is by increased prevalence of Candida albicans, hemolytic streptococci and staphylococci, and increased rate of dental caries. Obviously, there will be decreased salivary flow, so there will be increased rate of dental caries. So coming to the important part, that is the periodontal manifestations. You can see that there will be changes in the gingiva. There is enlarged gingiva, enlargement of the gingiva as due to increased inflammatory process. Sessile or pedungulated gingival polyps can be seen. Polypoid gingival proliferations can be seen. Severe gingival inflammation and increased bleeding on probing, increased clinical attachment loss, deep periodontal pockets. In children, it will be more in case of molar and incisor region, and where there is type 1 diabetes mellitus. And also you can see rapid bone loss and frequent abscess formation and loosening of teeth. Periodontal disease is considered to be the sixth complication of diabetes. So, to the factors responsible for the altered response seen in the tissues of diabetic patients. So, we can define it in different aspects. So, there will be changes in bacterial pathogens, there will be altered cellular response, there will be altered collagen metabolism. So, these are the main factors which are responsible for the altered response in tissues. So, coming to the bacterial pathogens. So as we said before, there will be increased glucose level in case of gingival fluid and the blood. So which obviously will change the environment of the flora. So there will be qualitative changes in the flora, that is there will be more amount of capnocytophagia. You can see that increased amount of capnocytophagia. In various studies they have proved that in type 1 diabetes mellitus you can see increased amount of capnocytophagia. And in type 2 diabetes mellitus, there will be more amount of Porphyria monogingivalis, Peribotulia intermedia, and Campylobacter rectus. So these are the bacterial pathogens, the role of bacterial pathogens. So there will be increase in amount of pathogens or in the quality or in the virulence factors. This can influence the response of the tissues. So coming to the altered cellular response, you can see that there will be altered function of neutrophils, that is polymorph neutrophils. So in case of chemotaxis, that is the locomotion of the like cells to the area where there is foreign body. So there is impaired chemotaxis will be there, defective phagocytosis, and the impaired adherence can be seen. Therefore, the primary defense mounted by the PMNS will be affected. So this is affected. That is the altered cellular response of PMNS, that is, and also there will be hyperactive response of monocytes. You can see that there will be increased amount of inflammatory mediators, that is pro-inflammatory cytokines, interleukin 1 beta and TNF alpha, and there will be increased tissue breakdown as a result of this inflammatory mediators. So coming to the altered collagen metabolism. So there will be alteration in the collagen metabolism both in the synthesis and in the breakdown. So this hyperglycemia affects the synthesis, maturation and maintenance of collagen and extracellular matrices. And there will be increased collagenases activity, enzyme activity will be more, the destruction of collagen will be more, and some of the proteins and matrix molecules in the structure will undergo non-enzymatic glycosylation. So this leads to some amount of accumulated glycation end products. So there will not be enzymatic glycolation, they will undergo non-enzymatic glycolation, and there will be formation of AGS. There is the accumulated glycation end products, so which leads to cross-linking of collagen. So this cross-linking of collagen which will be less soluble and unrepairable. So there is thus there will be no renewal of collagen at a normal rate. So both these AGs and the receptor for AGs play an important role in the progression of disease. So these are the factors that are responsible for the altered response, for bacterial pathogens, altered cellular response, and altered collagen metabolism. So coming to the glycated hemoglobin value, so there is a HbA1c. There is a test that reflects glycemic control over 2 to 3 months. So this test is performed in a laboratory using a method that is certified by MGSP and diabetes control and complications trial, just for the information. And this has given a laboratory value for evaluating the diabetes. It is 4% is considered as normal, less than 7% good diabetic control, 7 to 8% that is moderate diabetic control, and greater than 8% action suggested to improve diabetic control. So therapeutic goal for many patients is to achieve and maintain HbA1c below 8%. So patients with relatively poorly controlled diabetes often have a poor response to treatment with more postoperative complications and less favorable long-term results. So HbA1c of less than 10% should be established before any surgical treatment is performed. So there are various studies proved that adults who are 45 years of age or older with poorly controlled, that is greater than 9%, were 2.9 times more likely to have severe periodontitis than those without diabetes. So coming to the reasons of poor wound healing in diabetic patients. So we already discussed about the altered response in diabetic patients, the factors responsible for it. So coming to the details of poor wound healing, the factors responsible for poor wound healing, that is, the first one is that, so as we said, there will be increased plasma glucose levels which lead to increased GCF fluid glucose levels in individuals with diabetes. So this high rate of glucose in GCF directly hinder the wound healing capacity of the fibroblast in periodontium by inhibiting the attachment and spreading of these cells, that is crucial for wound healing and normal tissue turnover. So this is directly affecting on the fibroblast in inhibiting the attachment and spreading of the cells for that is crucial for wound healing and normal tissue turnover. So there is a first factor that is responsible for poor wound healing. Coming to the next, that is the production of advanced ligation end products. As we said, that is the proteins and they undergo non-enzymatic glycosylation and they form AGS. So this forms cross-linking collagen cross-linking, leading to the formation of collagen macromolecules that sustain normal enzymatic degradation. That is, normal turnover of collagen or renewal of collagen will not take place. That is the second factor. The third factor is that human fibroblasts produce decreased amounts of collagen and glycosaminoglycans in the hyperglycemic state. So the residual newly formed collagen is highly susceptible to enzymatic degradation by collagenase, so which is most present in active form in people with diabetes. So that collagenase activity will be more, and also the fibroblasts will form only decreased amounts of glycogen and glycosaminoglycans. So these are the three factors that is responsible for wound healing. There is the first one, the fibroblast activity in case of attachment and spreading of cells. Second one, by the formation of AGs, so that cross-linking of collagen will happen, so that normal enzymatic degradation will not happen and the collagen renewal will not happen. The third one is that in the hyperglycemic phase, the fibroblast will produce decreased amounts of collagen, and also the collagen formed by the limited amount of collagen formed will be highly susceptible to enzymatic degradation by collagenase, which is active form in people with diabetes. So coming to the risk factor, as you know, the pathogenic bacteria and microbial tooth deposits. So the accumulation of bacterial plaque, the gingival margin, results in development of gingivitis. That any foreign body which is getting accumulated will be which will lead to the gingival inflammation, and this can be reversed with the implementation of oral hygiene measures. But patients with severe loss of attachment, sometimes you can see that patients with severe loss of attachment with minimal amount of bacterial plaque. So this indicates that the quantity of plaque is not of major importance in the disease process, but the quality of the plaque. So there is, however, although quantity may not indicate risk, there is evidence that the composition or quality of the complex plaque biofilm is of importance. So in terms of quality of plaque, mainly three main bacteria have been identified as etiological agents in periodontitis. That is Aggregatibacter actinomycetum comitans, Porphyria monogingivalis, and Tannerella fluorescens. Coming to the additional evidence that they are causal agents, the evidence is that is proved to be as the causal agents include their elimination or suppression impacts the success of therapy. There is a host response to these pathogens. Virulence factors are associated with these pathogens, and inoculation of these bacteria into animal models induces periodontal disease. So these are the additional evidence that proves that these three bacteria are the causal agents. Although not clearly defined as risk factors for periodontitis, anatomic factors and restorative factors also influences the plaque accumulation, may play a role in disease susceptibility for specific teeth. Then the presence of calculus, so which which directly does not cause periodontitis, but which can act as a reservoir for bacterial plaque. So that is considered as a risk factor for periodontitis. Although the presence of some calculus in healthy individuals receiving routine dental care does not result in significant loss of attachment, the presence of calculus in other group of patients, such as those not receiving regular care and patients with poorly controlled diabetes, can have a negative effect on the impact on the periodontal health. So coming to the another risk factor that I would like to explain, that is the vitamin C. Okay, so that is the vitamin C. It has a major role in our health and especially on the periodontium. That is otherwise called ascorbic acid. So it has various roles. Mainly there are 6 roles of vitamin C. There is first one, low levels of ascorbic acid influences the metabolism of collagen within the periodontium, thereby affecting the ability of the tissues to regenerate and repair. So mainly on the metabolism of collagen. So if there is any low levels, what can happen? It can affect the ability of the tissues to regenerate and repair itself. The second one is that its deficiency interferes with the bone formation. How it can affect the bone formation? By failure of the osteoblast to form osteoids. So decreased activity of osteoblast. So which leads to loss of more amount of bone. So that is the second one. First one is collagen metabolism. Second one is the bone formation. Third one is that vitamin C is needed. The optimal levels of vitamin C is needed to maintain the epithelial barrier function to bacterial products. So its deficiency, what happens? It will lead to increased permeability of the oral mucosa. So that is the third one. There is the barrier activity will be hampered. The fourth one is that which enhances the chemotactic and migratory actions of leukocytes. So when there is deficiency, there will be decreased amount of chemotactic and migratory actions and phagocytosis activity. So there is the fourth role. Fifth role is that optimal level is required to maintain integrity of periodontal microvasculature as well as vascular response to bacterial plaque and wound healing. So if there is any decreased amount of ascorbic acid, there will be decreased maintenance of the integrity of periodontal microvasculature and decreased response to bacterial plaque and decreased amount of wound healing. Sixth one is that depletion of vitamin C may interfere with the ecological equilibrium of the bacterial plaque, and thus it increases its pathogenicity. So if there is depletion, if it interferes with the equilibrium, what happens? There will be increased amount of pathogenicity. So these are the 6 roles. I just want to repeat once more. First one is collagen metabolism and interfering with the repair and regeneration. Second one, bone formation. And third one is barrier action. And fourth one is the chemotactic and leukocytic activity. And fifth one is that the integrity of periodontal microvasculature and the wound healing. And sixth one is the equilibrium, ecological equilibrium. So this increases the pathogenicity. So coming to the risk determinant, there is a first factor, that is genetic factors. So these are risk determinant are factors that cannot be modified. Genetic factors, there is evidence that genetic differences between individuals may explain why some individuals develop periodontal disease and others do not. So studies that has been conducted in twins have shown that genetic factors influence clinical measures of gingivitis, probing depth, attachment loss, and interproximal bone height. Out of that, there is alteration in the interleukin 1 genes may play a valid marker for periodontitis in defined populations. Mainly, the immunological alterations such as neutrophil abnormalities, monocytic hyperresponsiveness to lipopolysaccharide, and alterations in the monocyte or macrophage FC via to the receptor for like IgG2 also appear to be under genetic control. So these are the alterations that can usually happen due to the genetic factors. Coming to the age is also is a risk factor that cannot be modified. Yes, periodontal disease is not an inevitable consequence of the aging process. That aging does not increase the disease susceptibility, but there can be changes related to aging process. As you know, there will be medication intake, decreased immune function, or altered nutritional status interact with other risk factors. For example, other diseases, systemic diseases can be there. So this will all help increase the susceptibility to periodontitis. Age itself as such will not cause the disease, but all these factors can lead to periodontitis, or the response to therapy also can be affected. There is young individuals with periodontal disease. So when you compare there is with the younger age group with periodontitis and like older age with periodontitis, you can see that younger ages with periodontal disease may be at increased risk for the continued disease as they age. That means younger individuals having the periodontitis means they are having the increased aggressive type of disease. So that is why it is like young individuals with periodontal disease may be at greater risk for continued disease as they age. So coming to the gender, there is no such differences, but we have found that men have poorer oral hygiene than women, as evidenced by higher levels of plaque and calculus. Therefore, gender differences in the prevalence and severity of periodontitis appear to be related to preventive practices rather than by any genetic factor. Coming to the socio-economic status, gingivitis and poor oral hygiene can be related to lower socio-economic status. That is, this can most likely to be attributed to decreased dental visits. So there might be having decreased nutritional um, level or decreased dental visits. So these can lead to some amount of increased progression of the gingivitis to periodontitis. So when compared with those with educated individuals of higher socioeconomic status. Coming to the next risk determinant, that is the stress. Emotional stress may interfere with the normal immune function. As you know, when there is stress, it produces like hormones like cortisol, so which acts as an anti-inflammatory agent. So when it is produced and it leads to the stimulation of mast cells to produce some protein, so this will increase the inflammation. So when there is increased amount of circulating hormones which can affect the periodontium. For example, in some diseases that is due to stress, that is caused as acute infections like ANAP, which increases during the periods of emotional and physiological stress, and suggesting there is a link between the two. Although epidemiological data on the relationship between stress and periodontal disease are limited, so that can be a putative risk factor for periodontitis. Coming to risk indicators. So risk indicators, as you know, there is it's identified with cross-sectional studies, not with the longitudinal studies. So evidence suggests that AIDS-affected individuals who practice good preventive oral health measures, effective home care, and seeking appropriate professional treatment can improve the periodontal health. Therefore, it is reasonable. Although it seems reasonable to hypothesize that HIV infection and suppression are risk factors for periodontal disease, the evidence is not conclusive. So there is it associated with HIV and acquired, which increases susceptibility to periodontal disease. That is identified only through cross-sectional studies. The degree of immunosuppression increases in individuals with AIDS, periodontal pocket formation, and loss of clinical attachment also increases. There are evidences like there are increased pocket formation and loss of clinical attachment. So coming to osteoporosis, that is which does not initiate periodontitis. Evidence indicates that reduced bone mass seen in osteoporosis may aggravate periodontal disease progression. However, it appears there is a link may exist between osteoporosis and periodontitis. Osteoporosis, that is the decreased bone density. So additional studies may need to be conducted to clearly determine that osteoporosis is also like a risk factor for periodontal disease also. So that's about the um, osteoporosis. Coming next is the infrequent dental visits. There is identifying failure to visit the dentist on a regular basis as a risk factor for periodontitis is actually controversial, and it's not that much evidences are proved, and additional longitudinal intervention studies are always necessary to determine if infrequency dental visit is actually a risk factor for periodontal disease or not. So coming to next is the previous history of periodontal disease. There is, if there is any history of periodontal disease, there is a good predictor, clinical predictor of risk for future attachment loss. So always the proper follow-up is needed for the previous history of periodontal disease or the patients who have undergone flap surgery for periodontitis. So patients with more severe existing attachment loss are at greater risk for future loss of attachment. Conversely, patients currently free of periodontitis have decreased risk of developing loss of attachment than those who currently have periodontitis. So coming to the next risk predictor, that is a bleeding on probing. That is, bleeding on probing is the best clinical indicator of gingival inflammation. But the presence alone will not uh, indicate the future attachment loss. But although bleeding on probing alone does not serve as a predictor, that is, when it is coupled with increased probing depth, may act as an excellent predictor for future loss of attachment. And also, the lack of bleeding on probing does appear to serve as an excellent indicator for periodontal health. Okay. So coming to the details of each, that is the clinical risk assessment, how we can evaluate the risk factors in various aspects while we are taking the case history. So as you know, we have already discussed the periodontal assessment, the case histories for gingivitis and periodontitis. So we will be just seeing that which all aspects will be monitored in each level. That is demographic data. Under demographic data, age will be taken. There is duration of exposure to risk assessment to evaluate the age, and according to age, we will be able to evaluate, that is, whether the like women are postmenopausal, and evidence of aggressive disease can be defined, and also the gender can be defined, and there is males, there will be decreased preventive practices, and the frequency of care will be less, and also socioeconomic status will be monitored under demographic data, that is gender awareness and frequency of care. So under medical history, we will be able to know there is the any that is diabetes, history of diabetes, tobacco smoking, or AIDS, osteoporosis, or stress. Then under dental history, we will be able to know the family history of early tooth loss, genetic predisposition to aggressive disease, previous history of any periodontal disease, and frequency of dental care. So these all will be taken under dental history. And clinical examination, we will be able to know the plaque accumulation, and it can be like microbial sampling can be done for the putative periodontal pathogens. The presence of mainly three pathogens, that is, as you know, Aggregatibacter actinomycetum comitans, Porphyria monogingivalis, and Tenella faucendia. And calculus, bleeding on probing, and the extent of loss of attachment, and the aggressive nature of disease, whether it is the deposits are consistent with the attachment loss. And also tooth examination will lead to know about the plaque retentive areas, anatomic factors, and the restorative factors, whether there is any overhanging restoration or contour. So these are the factors we will be assessed in various levels of extracting the case history. So coming to the periodontal risk assessment. So in the era of electronic health records, having a clinical assessment tool is very important. So this allows the clinician to perform the risk assessment and develop the personalized treatment plans quickly and effectively. So that is the electronic risk assessment, and there are various investigations are there. That is, so one is periodontal risk assessment. So this one, which determines the patient's periodontal risk for further disease progression and attachment loss. So this is mainly like found by There is Lang and Tonati in 2003, following 6 parameters, mainly based on 6 parameters. He categorized into low, medium, and high. So coming to the 6 parameters, he has developed a hexagonal structure. So what are the 6 parameters? There is bleeding on probing percentage. There is a number of teeth with pocket depth greater than or equal to 5 mm, and number of lost teeth, percentage of bone loss related to age, and presence of systemic factors and presence of environmental factors. So these are the 6 main factors he took into consideration. So this is the functional diagram or hence hexagonal diagram like found by Lang and Tanati. So as you know, there is he has uh, made a hexagon form of diagram. So you can see that it has 6 points, and the innermost hexagon column is this for the low risk, and the middle darkened portion is to demarcate from moderate to high. So this is bleeding on probing percentage, probing depth, or like number of teeth of probing depth greater than or equal to 5 mm, the number of tooth loss, that is bone loss by age, and presence of systemic factors and environmental factors. Mainly we are considering the smoking patient. So we will come into details of each. First one, there is the percentage of bleeding on probing. So how we can calculate the bleeding on probing? So it is objective inflammatory marker, as you know, bleeding on probing. So there is so when it is coupled with the periodontal pocket, it is a good indicator, as we said before. And absence of bleeding on probing is a good indicator for the stability. So here you can see that it is given in squares. So as you know, it is the squares. There is a 4, 9, 16, 25 and 36. So when it is considering, it is still 9, it is low risk category, and above 9 it is still 25, it is moderate risk category, and if it is above 25 it is high risk category. So it is determined by light probing to the bottom of pocket with a standardized periodontal probe. So the periodontal score is comprises the number of posterior sites divided by the total number of sites multiplied by 100. So this is how we are getting the bleeding on probing. So this is till 9 it is low, till 25 it is moderate, and above that it is high risk. So it is bleeding on probing. Coming to the next factor, that is the number of periodontal pockets with probing depths greater than 5 mm or deeper, that is the pocket depth, so which indicates a future attachment loss. So there is given in a linear fashion. The numbers are given in a linear fashion. There is the even numbers 2, 4, 6, 8, 10. So there is the periodontal pockets with greater than is not the tooth with, there is a periodontal pockets how many with greater than or equal to 5 mm. Okay. So the individuals up to 4, it is considered as low risk category, and as you know it's in the picture, and still 8 it is regarded as the moderate risk category, and if it is greater than that it is high risk category. So this is the number of pockets with probing depths greater than 5. So coming to the number of lost teeth, as you know there is wisdom teeth which are listed measly. If that is in function it is considered, otherwise third molars are not considered as the lost teeth. Okay, so that is more than 8 lost teeth function is heavily compromised. Okay, so there is the, it is also in a linear fashion. There is the 2, 4, 6, 8 and 10. So there is what we told, there is 28 teeth will be counted. And individuals up to 4 teeth lost, it is low, and till 8 it is considered as moderate, and greater than that high risk category. So coming to the next factor, that is the percentage of bone loss related to the age of the patient. So 1 mm is considered as 10%. You can see that 1 mm is considered as 10%. So this is 40%, and this is the 60%. As you know, there is in the picture, there is 1 mm is considered as 10%. Okay. and you can see that it is 2 mm below CEJ. So it will be counted from 2 mm below CEJ, and if it is bone loss is greater than their age, obviously it will be with higher risk. Okay, so the percentage of bone loss is estimated from the radiographs. So we need to know the radiographs uh, for the finding out the percentage of bone loss in related to age. So baseline, it will be 2 mm apical to CEJ, and in cases where peripheral radiographs are not available, bite wings can be used and for the purpose, and it is estimated 10 percentage per mm. So you can see that it is given us in the, there is 0.25, 0.5, 0.75, 1, 1.25. So this is inside, there is till 0.5 it is low risk category, till 1 it is moderate risk category, greater than that considered as high risk category. Okay, so this is the third one, that is the percentage of bone loss related to the age of the patient. So then coming to the systemic factors, there is, we are considering only the presence of factors, systemic factors. There is the most sustained evidence for the modification of susceptibility or progression of periodontal disease arises from the studies on diabetes mellitus. So we are considering only diabetes. So if it is not in this case, the area of high risk is marked for the vector. Factors are not taken into account for the other factors. If it is not non or absent, systemic factors are not taken into consideration. So it is present or absent. So if it is present, it is high risk category. So coming to the environmental factors, we will be taking up about the smoke. So that is environmental factors. Environmental factors such as smoking may be considered as the sixth risk factor for periodontal disease progression in the functional diagram. So there is a sixth risk factor. The last one, the heavy smokers. So we have considered that is heavy smokers, that is smoking more than 1 pack per day. That is considered as high risk category. Okay, and heavy smokers, that is greater than 20 cigarettes per day. This, whereas non-smokers, so you can see that non-smoker and former smoker is considered as the low risk category, whereas occasional smoker and current smoker considered as moderate risk category, and heavy smoker is considered in the high risk category. Heavy smokers, that is smoking more than 1 pack, that is more than or equal to 20 cigarettes per day. Non-smoker and former smoker, that is at least the former smoker should be stopped at least more than 5 years in cessation. So that is considered as low risk category. Occasional smoker, that is the occasional smoker and smoker that is less than 10 cigarettes per day, and 10 to 19 there is a smoker. Got it? So this is greater than 20 cigarettes per day. Here it is 10 to 19. If it is less than 19, it is the occasional smoker. Former smoker means at least more than 5 years. At least 5 years should be there after the cessation. And the non-smoker considered as low risk category. Okay. So coming to the assessment of that is a low risk maintenance patient or moderate risk. Okay, so we will be given the factors, and you need to draw the diagram with the all the 6 factors and the values to be marked, and you have to note down which factor it is, and you have to shade the column inside. Okay, so for this case, it is a low risk maintenance patient. So all the parameters within the low risk. So at least one parameter in the moderate. So it is not, it is considered as a low risk. So if the 2 factors are there in the low risk, so it is considered as low risk maintenance patient. Okay. Then coming to the moderate risk, so at least if the 2 parameters are in the moderate, but at least one parameter in the high risk category, it is considered as moderate risk. Okay, there is the moderate risk category. And coming to high risk, at least 2 parameters if it in the high risk, it is considered as high risk. Okay, at least 2 factors should be there in the 1 factor. Okay, so low risk, it is 2 factors in the low risk, and moderate risk at least 2 factors and 1 in high risk, and high risk at least 2 parameters in the high risk category. Okay, so coming to the clinical risk assessment for periodontal disease. as you know, like we will be evaluating the risk at various aspects. That is, we have come across the all medical history, dental history, then we are evaluating the risk factors. So based on, as we said, that tobacco smoking, diabetes, we will be evaluating various factors, and we will be going to the treatment area. And so when there is irresponsive to the therapy what we have done, so if it is positive response, that means appropriate periodontal maintenance is needed. But if there is again negative response, we need to evaluate the risk once more. So that is the things that we need to do, that each category what all things we need to do, that is what we have given here. Okay, so there is a clinical risk assessment for periodontal disease. So these are the some of the like online platforms you can just practice the thing. There is a risk assessment tools are available. So in digital risk assessment tools, you have to just note down the you have to give the age and the number of teeth and the number of sites present, number of BOP present, and so they will be providing with the risk values. So this you can just, for example, I have given. So this you can just go through. That is the factors for each one, how you have to fill the. So this is something with low risk category, and this is with medium risk category. There is this, so this will, you will get this as a shaded area. So for exams you need to draw the diagram. Okay, so this is just for the way of getting the results. Okay, so coming to the risk assessment involves identifying elements that either may predispose a patient to developing periodontal disease or may influence the progression of disease that already exists. So it's useful in finding progressive periodontitis, definition of which was specified in 5th European workshop on periodontology as the presence of at least two teeth with greater than 3 mm proximal attachment loss between two observational periods. So it helps in evaluating, this risk assessment helps in evaluating prognosis reliability over the long term. So that's all for today. Thank you.